The following lecture is aimed for dental students, interns, junior trainees, junior residents of oral surgery and oral maxillofacial surgery, as well as junior residents of other dental specialties. I also dedicate this lecture to my fellow colleagues and dental practitioners of several dental specialties all over the world. May you all benefit from it. In memory of my late parents, may the merciful Almighty God rest their souls in heaven and peace. Please allow me to give a brief bio about the speaker. My name is Mohammed Al-Shulkami. I'm a professor of oral and maxillofacial surgery at the Faculty of Dentistry, Suez Canal University in Ismailia, Egypt. This lovely city, which lies around 120 kilometers to the eastern of the capital, Cairo, in Egypt. It was named after the late great ruler of Egypt, Khedive Ismail, the one who did the opening ceremonies of the Suez Canal in 1869. I'm also the professor and the supervisor of the Oral and Maxillofacial Surgery Department at Faculty of Dentistry, Sinai University, Kantara campus in Ismailia. I also worked as a part-time associate professor at MIU University and MSA University for several years. I'm a visiting professor at the Faculty of Dentistry, Beirut Arab University in the Oral and Maxillofacial Surgery Department in Beirut, Lebanon. I'm also the managing director of the Egyptian Dental Center, a multi-speciality discipline dental and maxillofacial center based in Cairo, Egypt. The main topic for today, I find it one of the most important topics in the dental practice, is the management of the medically compromised patients. And the topic of this lecture is the management of neurological disorders in the dental practice. We are going to go through two important medical conditions. First of all, seizure disorders, and the second is alcoholism. Regarding seizure disorders, we are going to discuss types and pathophysiology, drugs used for treatment, potential problems and risks, and last but not the least, the management protocol. What are the different types of seizures? First of all, we have the tonic-clonic seizures, formerly referred to as grand mal seizures or grand mal epilepsy. This is the typical form of seizures all people hear of or know, where the person cries out, fall to the ground and lose consciousness, and have muscle jerks or spasms for a certain period of time. Second, we have the absence seizures, formerly referred to as petit mal seizures or petit mal epilepsy, where there is rapid blinking for a few seconds or losing attention or staring into space. Then we have the myoclonic seizures. They are characterized by brief jerking spasm of a muscle or a group of muscles. They often occur in combination with atonic seizures, which cause sudden limpness of one of the muscles. Last but not the least, we have the tonic and atonic seizures, referred to as drop attacks. Usually they happen in children, but they also may extend to adulthood. The person's body will suddenly become limp. If the patient is sitting, the head or the upper body may slump over or drop, and if standing, the person may fall limply to the ground. Another serious variation called status epilepticus, where the seizure lasts longer than 5 minutes or having more than one seizure within a 5 minutes period, but without returning to the normal level of consciousness between these episodes. It's a medical emergency case that might lead to permanent brain damage or even death. Actually, seizures occur as a result of increased abnormal electrical activity in the brain, which finally leads to the muscle twitching and the different forms of muscle spasm as seen in the cases. The most famous treatment drug of choice for seizures disorders is Dilantin, and the Dilantin has a problem regarding the oral health. It causes gingival enlargement, and this requires surgical intervention. And of course, the role of oral hygiene is very important. Encouraging good oral hygiene measures and do good prophylaxis for the patient decrease to a great extent the gingival enlargement and the gingival hypertrophy. However, surgical intervention sometimes is inevitable. Now let's come to the potential problems. While treating an epileptic patient or a patient with seizure disorders, the attack might happen in the office, falling down and subsequent injury might happen. I remember a case used to come back in the 90s at Cairo University. The patient had a fractured mandible which resulted from falling down during an epileptic attack. The patient may bite the tongue, bite the lip, or bite the cheek and cause severe injury and might lead to bleeding from this injured site. Injury to the staff could happen, and damage to the equipment surrounding the patient like handpieces, electric motors, scalers, whatsoever. So in dealing with such patients, you have to make room for the patient's movement if he has an attack, and you should protect the patient himself at the first, and then you protect the staff and yourself, and then you protect your equipment. The patient comes first. Neurological evaluation and medical consultation should be done. It's important to know the frequency and the type and the duration and the sequelae of the attacks that used to happen for the patient. This is very important in designing your treatment plan. Stress reduction protocol should be implemented completely. Electroencephalogram may be useful for revealing any abnormal activity in the brain and the severity of it. If the patient had multiple procedures to be done, like multiple impacted teeth or surgical procedures or implant placement or sinus elevation or multiple restorative dentistry work, you might consider to resort to GA safely to overcome any problems in the outpatient clinic. Sedation also could be done after medical consultation. Patient protection is very important. You should be alert and cautious should the patient develop or has an attack during the dental treatment. You'd be able to protect yourself because your fingers are going to be under his teeth, or probably the patient might bite the operator's finger, or might bite his tongue as previously mentioned, or his lips or his cheek. So you should pay very good attention to patient protection. Use bite blocks or mouth props. The rubber ones, autoclavable ones, or the metallic one should be put on the non-working side to protect the patient from biting himself if he had an attack. And now let's come to alcoholism. We are going to discuss the potential problems with alcohol abuse and outlining the management protocol. First of all, the patient should be allowed to withdraw before any elective surgery to avoid alcohol withdrawal symptoms encountered when the patient stops alcohol. And these withdrawal symptoms range from minor symptoms, which are neuronal excitability, mild agitation, tremors, seizures, diaphoresis, and catecholamine release. However, it might reach a severe form like delirium tremens, where hallucinations, hyperpyrexia, hypertension, and life-threatening cardiac arrhythmias and seizures also with circulatory collapse. Let's see the potential problems encountered with alcohol abuse patients and the management protocol for each of them. Alcoholism is among the causes of liver disease and liver damage, so we can assess the liver condition by doing liver function tests, the ALT and AST, and the clotting profile INR and PT to understand the eligibility of this patient to undergo any oral surgical procedures. If the patient is not cleared enough from the withdrawal symptoms, or the liver is damaged to an extent beyond control in the outpatient clinic, we can consider after medical consultation of having the procedure done in hospital setting, so hospitalizing the patient to be under control in a safe environment. And then let's pay attention to drug interactions. Usually the alcohol abuse patients, they have increased demand for the induction dose required for general anesthesia. Also, the alcohol interacts with sedatives or drugs used during sedation. They potentiate the level of sedation and suppresses the gag reflex. So care should be taken when having a conscious sedation on the outpatient basis. Furthermore, there is a drug called sulfiram or antabuse. It was the first drug approved by the FDA in 1949 to treat chronic alcohol abuse. Some patients treated with disulfiram have, or treating patients with disulfiram have potential problems also. It can complicate anesthesia to produce sedation. It does complication with local anesthesia or any other CNS depressive drugs. It causes potentiation to the sedation action or the depression action of such drugs. Disulfiram also causes hepatotoxicity, and as we said, we should assess the liver condition. Last but not the least, what is called disulfiram phenomena. It can cause confusion, psychotic reactions such as delusions, hallucinations in some patients. Finally, we should have a look on what we call a disulfiram-like action. When we use the antibiotic, the famous antibiotic for the anaerobic bacteria, metronidazole or the flagyl, if this drug is taken in patients consuming alcohol, it is going to produce a disulfiram-like reaction, as if the patient is taking disulfiram. This manifests as violent abdominal cramping and severe nausea and vomiting. So please don't prescribe metronidazole for chronic alcohol abuse patients. Marcus Aurelius once said, "The happiness of your life depends on the quality of your thoughts." How simple. Finally, I would like to thank you for your kind attention. Thank you so much.